Looking at the upper extremity and the blood supply somatically to our musculoskeletal system, we have a couple different kind of key components to remember. We have our subclavian artery, our axillary artery, and our brachial artery. So we're going to focus on these three first. Our subclavian artery is on the right side going to be branching from the brachiocephalic trunk. Left side, it's going to come directly from the aortic arch. And kind of key branch points off of the subclavian artery are going to be the vertebral arteries, C6 through C1, the internal thoracic, and the thyrocervical trunk. The axillary artery is going to start at the lateral border of the first rib, and it's going to branch into the thoracoacromial, the lateral thoracic, the subscapular, and the circumflex humeral. And then the brachial artery, where you would assess a pulse here in the arm, begins at the inferior border of the teres major. It'll run to that medial portion of the humerus, and we can, excuse me, palpate it in the cubital fossa, and it gives off the deep brachial profunda brachii artery. Okay, if we're following progression down further, the brachial artery can bifurcate into the radial and the ulnar artery. The radial artery is going to be the lateral portion from anatomical positions, the lateral portion of the forearm, palpable at our wrist, our radial pulse. The ulnar artery, medial portion of our forearm, and it gives off a common interosseous artery. The palmar arches on the hand, we have a superficial palmar arch, mainly ulnar, and we have a deep palmar arch, which is mainly radial and digital arteries to our fingers. Venous drainage wise, we go cephalic, lateral, basilic, medial, and then median cubital. And they all drain then into the axillary, subclavian, brachiocephalic, and superior vena cava. So you could, to simplify the flow into the upper extremity, subclavian to axillary to brachial to radial ulnar to palmar arches to digital arteries. So knowing this flow pattern would be helpful because it's your branch points. And then from there, you'd want to be able to identify some key structures that could be served by those arteries. If you know when they're essentially bifurcating or when they're starting or stopping, as long as you know the general structures in that area, you could probably make some assumptions that would likely be right about blood supply to major areas or major tissues. Lower extremity, kind of same idea. So our progression point, just to start us off, we have our common iliac to our external iliac, femoral, then popliteal, then anterior and posterior tibial, and then the foot. So kind of how do we get here? At L4, our abdominal aorta bifurcates into our right and left common iliac arteries. Each common iliac divides into an internal and external iliac. The internal iliac is really going to be sending blood to pelvic viscera, our organs, the gluteal muscles, and the perineum. The external iliac is going to pass under the inguinal ligament, and it will be what becomes the femoral artery. The femoral artery is the main blood supply to all the structures in the thigh, and it's going to pass through the femoral triangle, again, under the inguinal ligament. It's going to separate, there is a deep femoral or profunda femoris, which is the thigh musculature, and then it's going to descend medially through the adductor canal. It will transition into the popliteal artery as the femoral passes through the adductor hiatus. Posterior to the knee, you can actually palpate this pulse, and it's going to give some branches to the knee joint. At the lower border of kind of the popliteal artery, it will divide into the anterior tibial and the posterior tibial artery. Anterior tibial artery will cross the interosseous membrane, and it's what becomes the dorsalis pedis at the ankle. Or at the foot, essentially, is where you can palpate it, but the ankle is where that transition happens. And the posterior tibial artery gives off the fibular or perineal artery. There's palpable pulses, the dorsalis pedis, posterior tibial, popliteal, and femoral. And so again, this is all like looking at just generally where these things are because there's so many things to memorize in NPLEX. Yes, like knowing that this muscle it gets blood from this artery, totally great. But when we have so much to learn and not a lot of time, or so much to remember and not a lot of time, at the minimum, knowing, okay, femoral artery is from here, like passing through the femoral triangle, enter the inguinal canal, to, right around when it's passing through the adductor hiatus. That's when it transitions to the popliteal artery. So everything in that space is likely given blood by the femoral artery, right? Maybe not everything, but most structures. All right, head and neck, we can kind of take similar like precautions here, and then we'll go through some venous return. So head and neck, we have our and we'll talk about this part too, like all these things we're going to touch on again. So it's not your only time. But we have our common carotid arteries. So the right from the brachiocephalic trunk, the left directly off the aortic arch. They bifurcate at C4 into the internal and external carotid arteries. The internal carotid, there's no branches in the neck. It's supplying the brain, the eye, and the forehead. And there are some key branches to note up there upstairs: the ophthalmic, the anterior cerebral, and the middle cerebral. Clinically, the middle cerebral is the most common artery affected by stroke. The external carotid artery, the other branch off the common carotid, is supplying our face, our scalp, our neck, our oral cavity, and it has lots of branches: facial, maxillary, superficial temporal, occipital, lingual. Use the name to help you identify kind of like where and what structures it could potentially contribute to. Now we have also some other branches from our aorta, right? We have branches off the subclavian artery, our vertebral arteries, and they are going to ascend upward through the transverse foramina of our cervical vertebra, C6 through C1. They enter into the cranium, the cranial space via the foramen magnum, and they join together to form the basilar artery. The basilar artery is supplying our brainstem, our cerebellum, our posterior cerebrum, and this is all kind of via these kind of offshoots of our pontine connecting arteries. But this is all our posterior connecting arteries or communicating arteries. But this is all kind of like supporting this back portion of the brain and this brainstem of the brain. Okay. The posterior circulation, the vertebral arteries and the basilar artery, if there's deficits, because they serve brainstem and occiput areas, they are going to have issues with balance, vision, and coordination if there's a deficit, if there's a blood supply loss issue. This is all going to connect from the basilar artery to this circle of Willis, which is an arterial anastomosis at the base of the brain, kind of where the brain's sitting on. And we have our anterior communicating artery, which connects the left and the right anterior cerebral artery. We have the posterior communicating artery that's going to connect the ICA to the posterior cerebral arteries. And we have all of these. The whole purpose of the circle of Willis is to give us some collateral circulation. This is going to decrease the risk of stroke because if one vessel is occluded, we can move around the circle and still get blood supply to most of our tissues of the brain. The carotid sinus is kind of a good baroreceptor for blood pressure regulation, and it's at kind of the C4 bifurcation point. And any sinus is a collection of blood. So just think of sinus as a collection of blood. How do we return blood back to the heart, right? We know the SVC and the IVC are really the ones that are directly draining in, plus the coronary sinus. Coronary sinus gets all the cardiac veins and it's draining into the right atrium. This SVC is draining our head and neck, upper extremities, and thorax, and it's formed by the right and left brachiocephalic veins coming together, and it goes into the right atrium. The inferior vena cava is draining our lower body, our abdomen, our pelvis, and it's formed by our right and left iliac veins at L5, and it moves up through the diaphragm at T8, and it goes into the right atrium as well. We also have this other kind of venous system, the azygous venous system. And this is a right-sided vein that connects the superior and the inferior vena cava, providing collateral drainage pathways. This is really helpful if the IVC becomes obstructed for whatever reason. There's also a hemiazygous and an accessory hemiazygous on the left-hand side. Okay, so there are collateral drainage patterns or pathways available if these big vessels get clogged for whatever reason. And we have to remind ourselves that veins themselves are capacitance vessels, meaning that they can be holders of the blood volume. 60 to 65% of body's blood volume is held in veins at any given time. And systemic veins and venules act as blood reservoirs. They have thin tunica medias and thick tunica externas, so they can stretch and they can hold a lot of blood easily. They also have venous valves that prevent any backflow. Most of those are in the limb veins, the most abundant, and venous sinuses. This is really where there's endothelium only. Our coronary and dural sinuses are the best examples. But the three ways we get blood back to the heart is via these venous valves, using our skeletal muscles as a highway pump, or a pump essentially, and then our respiratory system, our respiratory pump. And here are some examples here. You can see this hemiazygous on the left. You can see the azygous on more on the right. And then we have kind of our big superior vena cava, and then we have it cut through this section, but we have this inferior vena cava as well. Let's see here. We will stop. This is a good place to stop. We're going to stop here. When we come back, we'll look at different blood vessel types.